that this happens physiologically when the symptoms occur post-prandially, means just after the food. Shortly means for few days, or the patient may be the asymptomatic, and the no nocturnal symptoms mean the symptoms are not in the uh, night, only daytime. So that is called physiological GERD. The pathological GERD always has a symptoms, so many symptoms, esophageal and extraesophageal symptoms. There is the mucosal injury of the esophagus on that endoscopic examinations, and patients always have the nocturnal symptoms in the night. Then patient has the reflex of that gastric content and the mouth at the night time. So this is this kind of that. There is two type of the classification: physiological and pathological. So there is one very important structure which again and again comes in that play, that is the lower esophageal sphincters. We already had discussed, I think, in last lecture, that is not a single structure but a combination of that uh, 3-4 structures which make the esophageal orifice closed. Normally it is open only when the food comes through the esophagus to the stomach, and normally it remains closed so that it avoids the reflex of the gastric content in the esophagus. But somehow if that is that relaxes, remain relaxed and remain open, so that the gastric content is reflects into the esophagus. So as we discussed, not a single muscles, it is made up of that intrinsic distal esophageal muscles that tonically contracted. So and the muscular sling fiber of the gastric cardia, you see that, and the crura part, the diaphragm, this is the diaphragm, this is the part of the diaphragm, this is the circular muscles of that esophagus, and the upper part of that this muscles of that stomach. So these and that these all these structures work simultaneously as a sphincter, so that lower part of a sphincter remains closed. It acts physiologically somehow when the gastric may if there is a gas in abdomen, so to release the gas, that it is a kind of that wall type, it works at the wall type, when that there is the excess gas in the stomach, then you that comes to the mouth, and that at that time it relaxes and it opens. So this is the always remember, it is not a single structure, it is made up of the various 3-4 muscular structures combinationally. When they worked, then they call that lower esophageal sphincters. So what pathophysiology of the GRD is there? The pathophysiology includes, that is the primary barrier which is responsible for not the reflex of the gastric content in the stomach, that is the lower esophageal sphincters. So if that anyhow this primary barrier, lower esophageal sphincters, is not worked properly, in that conditions this happens. So if the barrier disrupted, the acid goes into the from the stomach to the esophagus, and that causes the esophagitis of the lower part of the esophagus, and the reflexes of the acidic content in the esophagus that occurs in the usually if the patient has the hiatus hernia, in the hiatus hernia is nothing, just the functioning of that lower esophageal sphincters, so that the part of the stomach, the cardia, is rolled out or the slide out into that esophagus, and goes beyond the diaphragm, so that there's the symptoms appear. You understand? That is the first the barrier which is responsible uh, for that remain gastric content in the stomach, that is the LES. If the LES is not functioning properly due to the impaired muscular defense or the excessive peristaltic movement, or any kind of other is or sometimes as sometimes what happens, the LES is working properly, but if that the acid is excessive secretions, acid the gastric juice is secreted excessively, so that it causes that reflex into the esophagus, or sometime that the gastric motility, the peristaltic movement in the stomach is not properly, so that the food is remain long time into the stomach, and that may cause the reflex. So these are the means various factors which are which play a important role in GRD, but the most important part is the LES. So this is the just hiatus hernia, just the rolling or that sliding of that stomach into the esophagus. You see that these are the kind of that hiatus hernia. Uh, all are same, but they on the basis of that that presentation, it is called sliding or the rolling type. Okay, so the most important thing is the hiatus hernia when the LES is not working properly, LES is weak, or maybe there are extra excessive pressure in the stomach, that may also cause the weakening of that LES. So that is these things means hiatus hernia is an anatomical defect that causes the GERD. Means that why most of the hiatus hernia patient always associated with the have the GERD symptoms, but all the GERD patient or with the GERD is not necessary to have the hiatus hernia, but most of the hiatus hernia patient must have the GERD. So the symptoms of the GERD is a variable. There is so many type of the symptoms. The esophageal symptoms include the heartburn, means that burning sensation in that just in the chest. Dysphagia, dysphagia means difficulty in swallowing. Odinophagia means the pain while the swallowing. Regurgitations and the belching. Regurgitation is sometimes when the gastric contents come to the mouth. And extra esophageal, the symptoms include the cough, wheezing, hoarseness of voice, sore throat, or the globus. The globus is nothing, just a foreign body sensation in the neck. So all these kind of the, it is not necessary to have all the features in single patients, but if somehow you see that any patient has the cough, wheezing, hoarseness of voice, means the extraesophageal, and other you cannot rule out any cause from the respiratory system, then you can suspect the patient may have the you must take the history of the patient may have the history of that GERD. So here is the dominance of the symptoms in the GERD. You see 80% of the patient of the GERD must have the heartburn, 54% have the regurgitations, 29% patient may have the abdominal pain, 27% have the cough. You see that these are the symptoms which may present in the GERD, but most of the symptoms means you can see that heartburn is the most common symptom in the patients of the GERD. And when we go down that there are some rare symptoms like that globus, wheezing and aspirations, or the belching, hoarseness of voice, dysphagia for solid cough. These is the percentage of the symptoms which are present in that. The dominance of the symptoms present in the patient of the GERD. Then come to the etiological factors, or that first factors aggravated the GERD. So etiological factors, that factors which affect the LES, or some other things that when the diet is plays very important role. uh, if the patient has take excessive caffeine, fatty acid foods, chocolate, coffee, peppermint, uh, citrus, alcohol, and the patient have the positioning of this means bending or the fasting for the after exercise, and smoking, external pressure, just like pregnancy, and the tight clothing, that hiatus hernia, and some medications also. It's very common. The most of that medicines, just like the NSAIDs and some antibiotics, yeah, may causes that excessive gastric secretions, and the patient of the hypotensions. You know that our gastric mucosa is very much uh, gastric as well as esophageal mucosa is very much sensitive. So if the patient is, we have already discussed, and the patient have the hypovolemic shock, so in the compensatory shock, our gut gives the blood to our the vital organs, so that that gut first goes into the hypotension. So that's why if the gut goes into the hypotension, that the cells, mucosal cells, goes into the hypoxia and may damages that causes damage of the esophageal mucosa, or the wet esophageal mucosa, that may lead to the gastric ulcer or esophagitis also injury, means the hypoxia injury and then inflammation, you know. So this is the always related. Some parasites may causes that means parasite. If you have no other factors, if you have any patient and patient has continuous this GARD, and you are not able to diagnose any, and patient is not responding to the regular treatment, then you must think about that there may be some parasitic infestation. So in that case, you may deworming is may be required. So these are some factors which aggravate or they may cause uh, that GERD, symptoms of the GERD. Diagnostic evaluation, how you diagnose the case. So if the classical symptoms of the heartburn and regurgitation exist in the absence of alarm symptoms, these are the alarming symptoms. Alarming symptoms mean most important symptoms. If the patient have these kind of the symptoms, then you must take the patient seriously, and then diagnose thoroughly, and then treat accordingly. Understand, if means if a patient has GERD along with that dysphagia, early satiety, GI bleeding, odynophagia, vomiting, weight loss, iron deficiency, it means the severity is very high, means the patient may have very severe conditions. That why that the patient the food digestion is not proper, and absorption is not happening properly, so that affect the patient's weight loss and iron deficiency, and the patient may be anemic. So that's why if the any these out of these seven alarming symptoms, if the patient has along with the heartburn and regurgitation, patient have the alarming symptoms, then you can make the diagnosis clinically and start the treatment. Initiate means if a patient have the heartburn and regurgitation, you can start the treatment. But if the patient have alarming symptoms along with it, heartburn and regurgitation, then you must take that patient very seriously, and just do some more diagnosis to confirm and treat that. And because some other conditions, just like esophageal, that gastric ulcers, peptic ulcers, or some other carcinoma of the esophagus, carcinoma of the stomach, also have the symptoms of the GERD. That's why if the patient has these kind of the symptoms, alarming symptoms, mean patient may have some other pathology also. So first, that are more serious pathology. So we should rule out these pathologies. So diagnostic tool, we already had discussed what are the diagnostic tools used for the management of these esophageal disorders. That include that barium enema, endoscopy, that and the pH monitoring, 24 spirits monitoring, that may be that ambulatory or impedance esophageal manometry for the measurement of the esophageal movement, as well as that pressure in the esophagus, the competency of the lower esophageal sphincters, and esophagogastroduodenoscopy. So that is the more important features. I suggest you, if you have patient of that GRT, means the patient has the heartburn and typical heartburn and regurgitations and or dysphagia and having the history of very long time and relapsing again and again, and then you may advise to the patient esophagogastroduodenoscopy to first rule out any other underlying cause, that's like the gastric peptic ulcer, gastric ulcer, or that any malignancy. Then you go for that medical treatment. My advice is you that this is the best diagnosis tool, esophagogastroduodenoscopy, because you may what the good thing is that when you do when you the patient is under that this esophagogastroduodenoscopy, so if somehow any person has any lesion, any mass, then at the same time that for the diagnostic of this GERD, along with this, if the patient has other pathology, so you can take the biopsy at the same time to confirm the diagnosis if there is any malignancy or not. That means the mass, and I understand means any ulcer or mass or something is there, so you can rule out in the same time. And so management, how you management, the goal of management of that GRD, first goal should be the relief in the symptoms. Patient should be relieved with the symptoms. Then if there is any inflammation esophagus, then that should be healed, esophagitis. And the third goal should be to prevent and treat the complications. If there are any complications, then you should first try to prevent the complication. If already exists, then treat these complications and maintain the remission. Okay, so that relapse may not occur. Now the treatment, what the treatment includes three things. First, lifestyle modifications, medications, and surgery. So the lifestyle modifications include, that is that as our being an Ayurvedic physicians or Ayurvedic doctor, we must think about this Ritucharya and Dinacharya, Ahara, Vihara. Means according to the Ritu and that Kal, our we should if the patient is taking a wrong Ahara and Vihara, then patient may have these kind of that features. Means that physiological GERD. So by modification of the lifestyle and the that diet, we can manage most of the cases of the GRD if the cases are non-chronic or any permanent damage is not there. Understand? So most that's why it's very important to understand what is the lifestyle of the patient. So the proper history is also required before the starting the treatment. What diet is patient taking, so you can advise the correct diet according to the prakriti of the patient, according to the ritu, according to the that kala, the agni. You know that as per Ayurvedic students, we all have the agni is very important. So Agni is the nothing, just the correct amount of that gastric juices or that intestinal juices, means intestinal enzymes. If they are on correct amount, then the Agni is correct. Means you can digest all food what you are taking. But if somebody has that Mandagni. So Mandagni is nothing, just maybe that hyper secretion or hyposecretions of the gastric or that intestinal juices, because the pitta is very important factor, that for the digestions. And the pitta is always has the yeah, I'm not going there. That pitta has the guru drava, kind of the this drava. Pitta has drava, means it has agni, but it is a liquid. So if that the water is very hot, hot water includes so much heat inside, latent heat, but it cannot burn. That hot water cannot burn anything. Understand? So that's why if patient has excessive gastric juice, that may also not good for the proper digestions. The correct amount of that juice, gastric juice, is required for that digestion, proper digestion. So that is the different topic. So the three things are there: lifestyle modifications, medications, and the surgery. So the lifestyle modification includes, if the patient is overweight, then first advise the patient to reduce some weight. Avoid tight clothing so that it increases the pressure in the abdominal, so that it increases the pressure in the gastric, so that may also cause the regurgitations. Modify diet, eat more frequent but smaller meals to tackle the mandagni, and avoid excessive use of the fatty or fried food, peppermint, chocolate, alcohol, and the carbonated beverages, cold drinks, coffee, tea, and the onion, garlic stuff. And if a patient is smoking, then patient must should stop smoking immediately. So these are the, if the patient is having a history of the hiatus hernia, then you can advise the patient to elevate his the head side 4 to 6 inch. So if the patient is lying down, that that stomach content is not rolling back into the esophagus, so that that symptoms may be relieved. And avoid eating within 3 4 hours of the bed times, because if the patient is just taking meal and just after taking meal is lying down, so that it may cause the regurgitation in the esophagus. And some meditations to reduce stress. Stress is also very important factor. Sometimes some patients due to the stress only, there is excessive secretions of that gastric juices, so that may cause that GERD, and that may and that may play very important role in the symptoms of the GERD. So these are the few tools to manage the lifestyle of the patient, so that patients may reduce in the symptoms, or sometimes may be treated also. If you are treating any patients with the medicines and you are not correcting the lifestyle, then patients may have relapse again and again. That is the main problem in that, because if some patient having this kind of problem and takes medicine for few days, and again starting these mithya hara vihar, means that that lifestyle is again incorrect, so that increase that fatty foods and these kind of that things, food to which exaggerated, that that relapse is very much common. The cause of relapse is of this GERD is that patient is not modifying his lifestyle. He just rely on the medicines. So for the medicines, just they act for the few days, and after that stop medicine, and patient not maintaining the lifestyle, then that's why the relapse occurs again and again. So the medication, there are four medications which are used in this condition. First, the antacids. Antacids give the just temporary relief. The H2 blocker receptors, that is the ranitidine, famotidine, cimetidine, that reduces the gastric secretions. Proton pump emitters, that rabeprazole, pantoprazole, and the prokinetic drugs. So these two drugs, H2 blocker and the proton pump emitter, reduces the secretion of the gastric juice, so that the hyperacidity may be reduced. And that prokinetics drugs, that they are the drugs which increase the gastric motility. So if there is a patients have that due to less gastric motility, the food is remain longer time in the stomach, that may cause also that esophagitis or that GRD. So if the gastric motility is there, so the food is moved through the from the stomach to the duodenum and to that small intestine. So that's why it may act, if the peristaltic movement is not proper in the patient, bowel movements are not proper movements, in that patient prokinetics may be used. So you see that effectiveness of that these drugs in this therapy, the lifestyle modification acts in the 20% of the cases very effectively. S2 blockers 50%, single dose PPI 80%, and increased dose PPI 100%. But this is the treatment. If you rely only on the drugs, then the relapse maybe the occurs. Then if the patient is not having uh, controlled, means symptom free with this medications, not responding to the medication, in that condition some one surgical procedure is also advised, that is anti-reflex surgery, that is called anti-reflex surgery. So this surgery is only indicated if the medical management is failed, but or the patient is preferring that does do the surgery, and I'm not want to take the medicines, or the patient has any complication of the GARD. Medical complications attributed to the large hiatus hernia, and patient may have the large hiatus hernia along with other complications, or the patient of the the atypical symptoms with the reflex documented on the 24 hours pH monitoring. Means after the 24 hours pH monitoring, you see that patient along on the bed, means that patient has the atypical reflex of that increase the gastric secretion, or reflex on the gastric pH, lowering the gastric pH. So in that cases, this surgery may be advised. So that surgery card is the fundoduplications. Fundoduplications. So this fundoduplication is nothing, just the upper part of the stomach is wrapped around the esophagus, so it increase the length of the esophagus, and the intra abdominal increase, it increase the intra abdominal, sorry, that the increase of the length of the esophagus below the diaphragm, so that it reduces the reflex, means lengthening of the esophagus. Okay, so if the patient has the hiatus hernia, in that cases that just repair of this alias along with this fundoduplication is has very much effective roles. uh, you see, with this surgery, quality life is improved in short term compared to the medical therapy, but there is an uncertainty in the benefits over surgery versus long term medical management with the PPIs. You know, you can manage the patient with the PPI also, but if in the short time, if you do the fundoduplications, then patient must have the relief. But then the long time use, the patient may again the relapses in the also common in this fundoduplication also. So that's why it's not advised in the first place. First place you do the medical therapy, and if the medical therapy is not working, in that case fundoduplication may be advised. So you can say in that just nothing, this is the, suppose this is the esophagus, this is the stomach, so this is the normal, and here US upper part of the stomach is wrapped around that esophagus, so that that esophagus, the stomach is not, stomach content is not going above the diaphragm, because and the stomach is remain here only. So the aim of this surgery is to restore normal anatomy, that is the intra-abdominal segment of esophagus. So in the hiatus hernia, what happens? The intra-abdominal segment of esophagus is nil almost, and it is shortening of the esophagus. So here we are doing with this fundoduplications the lengthening of the esophagus, recreating an appropriate high pressure sound at the esophageal junction, esophagogastric junction. Here we are creating one kind of the sphincters, because when the wrapping that stomach around the esophagus is, it gives the strengthening to the alias also, and maintaining this repair in the normal anatomical positions. So although some patients all is not cured properly, and they have some kind of that means some patients may have that the symptoms that like the dysphagia for the solid food, and some patients may have the 2-3% of the patient may have the complete symptoms permanently, means not relieving at all. So but and so few patients may have gas, bloating, diarrhea, nausea, early satiety. These kind of the features may be present in the post surgery, post surgery also. This, that's why it is not indicated first place. The complication of the hiatus hernia include the erosive esophagitis, the structure formations, Barrett esophagus, and adenocarcinoma. So that all of force, all I think all these erosive esophagitis means there is inflammation of the esophagus, along with the erosion in the inner wall. Stricture means that after the inflammations, when there is healing is there, so there is the fibrosis. So may call the stricture means narrowing the lumen of the esophagus. Barrett esophagus and adenocarcinoma. So adenocarcinoma is the changing of that means malignancy, development of the malignancy due to chronic irritation with the of the esophagus wall with the gastric content. And the same time Barrett esophagus is also same conditions. So Barrett, it is not a malignant, but it's a pre-malignant conditions where the due to that chronic irritation of that esophageal esophagus with this gastric content, there is changes, the metaplasia occurs in the inner layer of the esophagus, and that normal stratified squamous epithelium is changes into the columnar epithelium. So that columnar epithelium has the goblet cells that are usually present in the intestine. Means there is a change, change in the nature of the tissue. So that is the kind of the pre-malignant tissue. So that may develop the carcinoma in the later stage and the stricture in the later stage at the this lower part of the esophagus. So this condition is called the Barrett esophagus. So that's all from this topic. That's and you just join again with this any questions.